Hello everyone and welcome to my channel. Today we're going to review atrial fibrillation, so stay tuned. I like to start every video with definition. So AF is a SPT or supraventricular tachyarrhythmia. It's usually a chaotic, irregular conduction of depolarization. Atrial fibrillation, or AF, is usually caused by pirates, and you'll see in a bit what I mean. So pirates, it's an acronym used to remember all the causes of AF. So think about pulmonary causes like PE, pleural effusion, COPD, lung cancer, and pneumonia. Ischemic heart disease, including acute MI, and other cardiac diseases like hypertension and heart failure. Other causes could include cardiomyopathy, pericardial disease, and myxoma. So keep those in mind. Rheumatic valve disease as well, and mitral stenosis. So valvular problems. Alcohol or holiday hard, smoking, caffeine, thyrotoxicosis. How about those electrolyte abnormalities? Hypokalemia, hypomagnesemia, diabetes, and sepsis. Now remember, if the AF is alone, then it's usually idiopathic, which means none of the above is present. If you have a patient with an AF, you have to ask yourself, is this the first episode? Is this a recurrent episode, or is this a permanent episode, permanent AF? It could be acute if it's less than 48 hours and chronic if it's more than 48 hours. And we can have three types of chronic. Permanent AF, which is usually referring to refractory to card diversion, persistent and lasts more than 7 days or less than 7 days but requires card diversion, and paroxysmal, self-terminates less than 7 days, usually 48 hours. Now symptoms, we remember palpitation, syncope, shortness of breath, and angina, rate-related ischemia, and 20% are asymptomatic. Some common signs are increased heart rate, irregular pulse, and you're gonna notice that the apical pulse might be faster than the radial pulse, low BP, and absent A waves in GBP. Now, you know the symptoms and signs. Also, you need to know the symptoms of complications, so stroke and TIA and pulmonary edema. In the ECG, we're going to find absent P waves, we're going to find that there is irregular and small F waves. The RR interval is going to be irregular, basically means the distance between R waves is going to be irregular one from the other. Now, heart rate's going to be above 100. If the episode is prolonged, this could lead into transient ischemic changes like ST depressions. Now, if the ECG is normal, you could be dealing with a paroxysmal AF, so you should order a 24-hour ECG. If it's more than 24 hours apart, the episodes, then you could consider doing an event recorder, which is a 7-day ECG. We can also basic investigation like FBC, especially like if there's an anemia and the patient has heart failure, that could definitely trigger AF. Using these to see if the levels of potassium and magnesium. We can ask for other investigations like TSH to rule out thyrotoxicosis, LFTs, cardiovascular risk factors like lipids and glucose. So you have a patient that's coming with AF, you've seen in the ECG, you've done the investigations, what kind of imaging should you be doing? And the first line of you should think about cardiac causes with a transthoracic echo to see the causes and complications. However, if that's a bit abnormal, then you should consider a transesophageal echo, which is a lot better, and a chest x-ray just to see signs of heart failure. So we have a patient with AF, ECG, bloods, and imaging. How are we going to manage? So we're going to do a bit of rate control. Okay, now if rate control doesn't work, then we can move on to rhythm control. In some cases, you could use this as a first line, but first you should be going for trying to slow the heart rate, and second, decrease the risk of thromboembolism. Now, thromboprophylaxis, it's something very important in AF. So remember CHAT-BAS score? Well, This little fella is going to help us define which patients will require some sort of prophylaxis. So if there's more than 1 in men and more than 2 in women, chronic AF, this patient would definitely need some anticoagulation. But we need to weigh out the risk of bleeding with the HASPET score. So don't forget that. Generally speaking, if they have a score of 0, then no anticoagulation should be needed, but you can consider aspirin. If they have a score of 1, then you can choose between oral anticoagulation or aspirin. If they have a score of 2 or more, then you definitely should go for oral anticoagulation. Now there's 3 conditions that you should always prompt you to start anticoagulation. That's valvular disease, peripheral embolism, and intracardiac thrombus. Now let's discuss a bit of rate control and rhythm control. Rate control is usually recommended for patients above 65 and with ischemic heart disease, whereas rhythm control is more for less than 65 patients who are symptomatic. If there is a reversible cause for the AF, it's very important. If it's a new onset of AF, or if there is any cardiac heart failure. Now the first line is always going to be for rate control, beta blockers, bisoprolol. We can also use calcium channel blockers like verapamil or digoxin. And second line is a combination of the above. Now when it comes to rhythm control, if rate control fails or it's not suitable for the patient, then we should go for rhythm control. We are thinking about cord diversion. This could be electrical cord diversion or chemical. Now if a patient is hemodynamically unstable, then we should go straight for electrical cord diversion. We should try to anticoagulate the patient if possible, but if that will delay the treatment of cord diverting the patient, then we should go straight for that before we anticoagulate. Now the option is, if the patient's stable, we should do a pharmacological cord diversion with flecainide or imidazole. You should always follow your local trust policies and the ALS algorithm. We could do an elective cord diversion in patients with AF more than 48 hours. So we should try to anticoagulate 3 weeks prior to the DC shock or DC cord diversion. And if we think there's a risk of failing with the DC cord diversion, then we should give imidazole and sotalol together with the anticoagulation. Catheter ablation would be the definitive management. It should be used for medically refractory AF and young patients. So let's summarize. If you have an AF and the patient's stable or unstable is the big question. If it's unstable, go for a DC shock plus minus anticoagulation depending on if you can actually do it before. Don't delay the DC shock, okay? If the patient's stable, then you need to classify whether it's less than 48 hours, then you can go for pharmacological cord diversion. If it's more than 48 hours, you can think about more of a rate control kind of thing, and then possibly an elective DC cord diversion. Thank you for watching, and remember to subscribe. I'll see you again in another lecture with Dr. Luke.